Uh, okay. On the behalf of Ampok, uh, greetings to everyone from Kerala and around India. So we're continuing with our monthly case presentation, and today we have a case presentation on lymphoma with an interesting presentation. So it'll be done by Dr. Hemalata, who's a resident in medical oncology in Apollo, Mumbai. And we have two very eminent uh, examiners this time who will be leading her through the case. We have Dr. Deepa, who was my teacher as well in TMC Mumbai and currently working in CMC Vellore, a lot of experience in hematology. Welcome, ma'am. And we have Dr. George Abraham, who also my colleague in TMH Mumbai. Now he's assistant professor in RCC, dealing with hematolymphoid department. So welcome to Dr. George as well. So I think we can proceed. Start. We're on the dot at 7:30. Over to you, Deepa ma'am and Dr. George. Thank you.
Am I audible?
Yes, ma'am.
Okay, sure. So, dear students in varying stages of metamorphosis in DM, a very good evening to you all. Before we start this case presentation, I have three disclaimers to make. First is myself, Dr. Deepa, and my dear friend, Dr. George. We are here to pass you and not to fail you. So, dear Dr. Hema, please be calm, cool, confident, and answer the questions. The second disclaimer is always begin with the end in mind. You have already taken the complete history examination and you have a diagnosis or differential diagnosis in your mind. So the end is the diagnosis or the differential diagnosis. So every word that you are going to speak in the next 15-20 minutes should be adding to that end. That is a diagnosis. And the art of this case presentation is to navigate your whole case along your strong points so that you reach the discussion of your diagnosis at the earliest. So at the end of 1 hour, I hope that all of us here will leave this room as a fan of Dr. Hemlata. So that should be the purpose of this case presentation. And the third disclaimer is every question which we are going to ask you, we will not answers to everything. So in case you do not know the answer, you don't feel bad about it. There is no need to bluff or beat around the bush. Just say that you don't know the answer. We will tell you the right answer and we'll go ahead. And if you do not know the answer to a particular question, all that it means is at this particular point in your life cycle, you do not know the answer to that particular question. You are very knowledgeable. You know answers to thousands of other questions, which unfortunately we didn't ask you. That's all. And we'll give you the right answer so that at the next moment in your life cycle, you know the answer to that question as well. So our case presentation will have four parts. First is the subjective part, the history. Second is the objective part, the physical examination. Third is the assessment or the evaluation. And the fourth would be the planning and the management. And if time permits, we will try to go through certain areas which are not usually covered, like long-term long-term toxicities and survivorship issues as well. We will discuss that in case time permits. So, Dr. George, and over to you, Dr. Hemlata. George, anything you wish to add?
Nothing to add, madam. We can start with the presentation.
Sure. Dr. Hemlata, you can start.
Yes, ma'am. Good evening, everyone. So I'll be presenting the case of 37-year-old female homemaker from Ratnagiri. She presented with a chief complaint of difficulty in swallowing for 15 days and complaints of generalized weakness since 15 days and complaints of swelling of the face and neck and right upper limb for 1 week. And she also complains of breathing difficulty for 4 days. So history of presenting illness, the patient was apparently normal 15 days ago when she developed a difficulty in swallowing, which is insidious in onset, and she gives a she gives a history of difficulty in swallowing only for the solids, and it was not progressive and it is not associated with the pain, and she has not given any aggravating or the relieving factors. So and she also gives us history of generalized weakness since 15 days, which has limited her activities of strenuous activities and all. And she gives a complaint of swelling of the face, which was insidious in onset and gradually progressive to the neck and right arm. And it is increased in the morning and reduced in the evening. And it used to increase on bending forward and lying down position. It reduces on sitting. So
जब मुझे ये पेज में मैं जाता हूँ बाद में बहुत
she also complains of a breathing difficulty of 4 days, which was insidious in onset and gradually progressive. Aggravates on climbing stairs and on brisk walking, and reduced on taking rest. And there is no diurnal or the postural variation with respect to the dyspnea. And she has not given a history of.
Just to add at this point, what does generalized weakness mean here?
Sir, generalized weakness is she gives a history of weakness which was not there before, kind of a fatigue, and this is limiting her other than day-to-day activities, whatever she used to do, going outside the market, going and getting few heavy things. This is all limiting. So this is the history that she had given.
A better word to describe is will be fatigue than putting it as weakness. That would sound it more specific here.
Okay, sir. So there is no history of fever, weight loss, drenching night sweats, and pruritus. No complaints of cough with expectoration and hemoptysis. No complaints of headache, chest pain, blurred vision, and hoarseness of voice and noisy breathing. No complaints of swelling over the body and the breast. No complaints of abdominal and lower back pain. And there is no complaints of drooping of eyelids, double vision, and difficulty in speech and difficulty in doing the fine motor activities. So, past history, there is no history of similar complaints in the past. No complaints, no history of diabetes, hypertension, TB, seizures, asthma, and cardiac disease. No history of blood transfusion in the past, and no history of malignancy in the past. Mentioned history, age of menarche is 15 years and cycles were regular. Flow was 3 to 5 days for every 28 days, no clot. Obstetric history, she has para 2, living 2 and no abortion. And age at marriage is 15 years and age at the first child was 19 years. And age at second child is 29 years and adequately breastfed and tuberculized. Personal history, she is a non-smoker, non-alcoholic, diet mixed diet. She consumes mixed diet, appetite and sleep adequate. Bowel and bladder is not disturbed. No history of IV drug abuse. Family history is not contributory. Treatment history is not significant. Coming to the summary of the history at the end of case history is a 37 years old female with no comorbidities, presented with a dysphagia and facial and right arm swelling and shortness of breath, fatigue for shorter duration, with no significant past history and family history.
So at the end of history, what is your interpretation with the information which you have provided so far?
So the feature what she presented is a complication of a midline tumor. So the causes of midline tumor can be the symptom which is a mediastinal tumor. So the mediastinal tumors can be lymphoma, or it can be carcinoma lung, or it can be thymic carcinoma or retrosternal goiter, or to some extent it can be a DCT also.
Hemlata, can I just stop you for a minute?
Yes, ma'am.
So, I mean, what George asked you was a very simple question, and I think you just tried to make it a bit complicated. So, you have given a beautiful history, and whatever the patient shared with you, you have narrated to us in a very clear way. So at the end of your history, I want three things I want to know. First is all the symptoms which you said are localizing to which anatomical diagnosis? The abnormality, the pathology is in which anatomical part of the body?
It's in the mediastinum, ma'am.
Okay, why do you say it is in the mediastinum?
It's
Because
the mediastinal tumor which is causing the SVC syndrome.
okay, so there is obstruction of the upper aerodigestive tract with SVC obstruction, right? So that
Yes,
is
ma'am.
why you are saying that the anatomical localization of your pathology is in the mediastinum. We all know from our old anatomy days that in the mediastinum, the structures are what you call as battle, right? The brachiocephalus, the aortic arch, the trachea, the lymph nodes, and the esophagus. So upper aerodigestive tract obstruction with SVC obstruction pointing towards an anterior mediastinal mass. The second question is, from the natural history of the symptoms which you told, the OPD, the onset, progression, and duration, what is the most likely etiological diagnosis? I'm talking of a broad etiology. You have a short history of 15 days with progression of obstructive symptoms. What does that tell you about the etiology, the broad etiology?
Ma'am, it is looks like a lymphoma. So the short duration, very aggressive.
What prevents you from saying that it is a thymoma?
Ma'am,
So
thymus
that's what, tell me.
slowly growing tumor,
Slow growing tumor. Okay.
and it is more common in female, but it is slow growing tumor with her complaints, and it is of a short duration of onset. So I'm considering
Okay.
lymphoma over thymoma, ma'am.
Sure. So the simpler way of putting is it's a pathology in the mediastinum. It's a mediastinal mass with SVC obstruction, and it's a malignant process because it has a short history and rapid progression. And when you talk of common malignancies in the mediastinum, what are the three T's that come to your mind, which you already said 5 minutes before? Thymoma,
Ma'am,
teratoma, and a terrible lymphoma, right?
yes,
Yes, thymoma, as you said, because it's a short history, it is less likely. This is a female patient, so a mediastinal germ cell tumor is not possible. So we narrow it down to a lymphoma. That's what you wanted to say, right?
yes, ma'am.
What is there in the history which is against a lymphoma or which does not say for sure that this is a lymphoma? If those two things were there, we would have been more comfortable with saying a lymphoma at the end of history without going to investigations or examination. You have
Ma'am,
already mentioned it.
the
In your
swelling,
negative history, you have mentioned it.
yes, these symptoms and swelling, ma'am. Swelling, nodal swelling.
Yes, very good. What are the B symptoms? You know, right? We will not
Yes,
go through it because I think it has been discussed multiple times. You know, right? What B symptoms are.
yes, ma'am.
Yes, so B symptoms, and there are no other peripheral lymphadenopathy. So those are two things which, if present, would have made a diagnosis of lymphoma easier for us. Okay, so this is what we have at the end of history. Anything else you want to add, George, or we can go to the examination?
I would like to ask you the approach to superior vena cava obstruction in a 40-year-old lady, as per your history, in the case which I worked up, and also the same situation coming in a 60-year-old male. What is the difference in approach to the same presentation in a 37-year-old lady, which you have mentioned, and a 60-year-old male? How does it differ?
Sir, according to the investigation,
Can you please repeat? You are not audible. Himlata?
hello, ma'am.
Sorry, we couldn't hear you. Can you please repeat?
Ma'am, the approach according to the investigation and etiology also differs. For example, 60 years, if the male person is a smoker, we can suspect small cell carcinoma, more common than the non-small cell carcinoma. And in a female, 37 years female who is a non-smoker and lymphoma. With a short duration, we can suspect a lymphoma. And lung also can cause, but 2% of non-small cell lung carcinoma can cause SCCO compared to around 8 to 10% of small cell carcinoma.
So with this presentation, it is more likely that it could be a lymphoma. Now, having said that it is a lymphoma, what is more likely in the scenario which you have described, whether it is a non-Hodgkin's lymphoma or a Hodgkin's lymphoma?
Sir, I will go with a non-Hodgkin's lymphoma than the Hodgkin's lymphoma. I do agree Hodgkin's as well as non-Hodgkin's will cause mediastinal tumors and causes SCCO, but frequency-wise, when you compare between the two lymphomas, the non-Hodgkin's lymphoma has lower frequency compared to the non-Hodgkin's lymphoma.
One more point can you add, especially in this particular patient? Agreed, both Hodgkin's and non-Hodgkin's can present with mediastinal mass. One feature in the clinical presentation, which you elaborated in detail, which makes Hodgkin's lymphoma lower down in the list. Nothing is absolute in medicine, but between non-Hodgkin's and Hodgkin's, Hodgkin's comes lower down.
These symptoms, ma'am?
No. It's SVC obstruction. Okay. So when you have a patient presenting with a mediastinal mass, irrespective of whether these symptoms are there or not, if you have features of SVC obstruction, Hodgkin's comes lower down and non-Hodgkin's becomes higher up in the list. Can you tell me why it is so? Anyone?
The consistency of the lymph nodes is more rubbery in the Hodgkin's.
Okay.
Whereas in NHL, it will cause, it will be more firm and it can cause obstruction.
Okay, many reasons are there. One is Hodgkin's is not that aggressive as a non-Hodgkin lymphoma. And second thing is, it is less infiltrative. So as you said rightly, it's less infiltrative. So it doesn't infiltrate directly into the vessels and cause a direct obstruction. And especially if it is a nodular sclerosis type, there is that sclerosis or fibrosis, which makes the lymph node contained within the tumor. So those are some reasons. So whenever you have a mediastinal mass with SVC obstruction, keep non-Hodgkin's on top and keep Hodgkin's lower down. Nothing is absolute. Even if you get Hodgkin's, it can happen in our real life practice. But at the end of history, when you are asked to say between Hodgkin versus non-Hodgkin with a frank SVC obstruction, always think of non-Hodgkin's lymphoma. Okay. Please continue.
Which is more common in India as per the Globocan data, NHL or HL?
NHL, sir.
Okay.
So coming to the examination, general examination, a 37-year-old woman who is older female, who is a conscious, cooperative and well-oriented to the time, place and person. And after taking the informed consent from her and we have examined her, so her ECOG status is 2 and weight is 87 kg and height is 160 centimeter, BSA is 1.97 meter square and BMI is 33.2. She has a pallor and no interest, cyanosis, clubbing and generalized lymphadenopathy. Skin and thyroid normal, bilateral breast is normal. Vitals, pulse is 90 beats per minute and BP is 140 80 mmHg of left upper limb. So the respiratory rate is 16 breaths per minute. Abdominal thoracic and temperature is she's age febrile. Head to toe examination, there is no ptosis of eyelids and icterus and cyanosis. Oral cavity, mouth opening is adequate, hygienic good, and no ulcers on the buccal mucosa. Voltious ring is normal. Cervical, axillary, epitrochlear, inguinal, and popliteal lymph nodes are not palpable. Coming to a local examination of the face, neck, and upper limb, facial puffiness is present and which is bilateral and symmetrical and plethora is plethoric. Engorged vein present over the neck and anterior chest wall. Elevated jugular venous pressure pulse is elevated. No swelling in the bilateral cervical neck region and supraclavicular fossa. So on inspection, right upper limb is swollen, then the left upper limb, no redness or discoloration. ulcers on the limb. On palpation, there is no raised temperature or no tenderness. Edema of the right upper limb is present compared to the left limb, and it is fitting in nature. Mid-arm circumference of the right upper limb, so 14 centimeter when compared to the left side of 33 centimeter. Mid forearm circumference of the right forearm is 25 centimeter when compared to the left side 22 centimeter. Sensation over the right arm is present. Brachial and radial pulses are present. Movement at right shoulder joint, elbow and wrist joint is present, but range of movement is restricted. Movement at left shoulder joint, elbow and wrist joint is intact. Able to move, do the all fine motor activities from the right upper limb. So left upper limb, there is no edema, sensation are intact, and range of movements are normal. So systemic examination, the respiratory and cardiovascular system and parabdominal examination is normal. CNS, higher mental function is normal, cranial nerve is normal, and sensory and motor system is normal, reflexes are normal, skull and spine, no tenderness, and sternal tenderness is not there. So, summary, 37 years old female, a non-smoker, non-alcoholic with a complaint of dysphagia, dyspnea, and swelling of the face, neck, and right upper limb of short duration with no significant personal and family history. On examination, she found to have a facial swelling, significant engorged vein over the neck and chest wall, features suggestive of SVC with no significant lymphadenopathy.
Suppose if there is an additional finding of ptosis in your clinical examination, what would you suspect in this patient?
Sir, I will suspect it is the ptosis I have asked because the thymoma, majority of the thymoma will be associated with a myasthenia gravis. So in the myasthenia gravis, there will be a ptosis, there will be a double vision and a difficulty in articulation, difficulty in doing the fine motor activities. So basically, I wanted to rule out the myasthenia gravis.
What are the differential diagnoses for an anterior mediastinal mass in this age group?
Lymphoma, thymic carcinoma, and germ cell tumor and retrosternal goiter.
Hemlata, in your physical examination, while you were elaborating the different parts of your examination, there was one part which made me feel very relieved. You were talking of mediastinal mass with SVC syndrome, right?
Yes,
So, which was the most important part in your whole clinical examination, which makes the oncologist who is treating the patient quite relieved in an oncological emergency like SVC syndrome. The most common thing which you do. Yes?
Respiratory system?
Yes, the vitals, no? Patient is hemodynamically stable. There's no tachycardia, there is no tachypnea. So the patient is hemodynamically stable. So that is what makes an oncologist comfortable in a patient with a mediastinal mass with SVC syndrome. And to answer the question which George had asked, it's very simple. You think of the T's. The T which you already said, that is thymoma, a teratoma or a testicular malignancy, especially in a male, then a terrible lymphoma and thyroid swelling. So these are the common swellings which you should think of when you think of a mediastinal mass. And in the examination, what were the positive things in the examination? Positive findings in your examination? There were features suggestive of SVC syndrome. Anything else?
No one.
No. So
only
patient had an ECOG performance status of 2.
Yes, ma'am.
Vitals were stable. There were features of SVC obstruction. And what are the specific features you would look for when you are thinking in the points of lymphoma? When you are thinking in terms of lymphoma?
The lymphadenopathy, ma'am.
Yes, very good.
And the hepatosplenomegaly.
Very good. And if it is a male patient, testicular involvement.
particularly.
And very good that when you measured the vitals, you said that blood pressure you measured in the left upper limb because of obviously the swelling in the right. That is good. Okay, so at the end of your history and examination, if you are asked to give your diagnosis or differential diagnosis in order of priority, how will you put it? Of course, we'll treat it after the complete evaluation, biopsy, and all that. If you are asked to say 1, 2, 3, 4, 5, what will be your diagnosis and differential diagnosis at the end of your very beautiful history and examination?
Ma'am, I'll put lymphoma and
Yes.
the thymic thymoma, then the retrosternal goiter, then the CLM, ma'am.
Do you think this is a retrosternal goiter?
No, the thyroid is not there. The neck.
So that's what I said. When you are asked to say differential diagnosis, it doesn't mean that you have to put everything that you have read. Think of this particular patient, 37-year-old lady whom you have seen, and what all practically you think would be common and which you would suspect in this patient. There is no need to put like 10 differentials for every patient. So you're thinking in terms of lymphoma and thymoma, right?
Yes, ma'am. A lymphoma and thymoma.
Okay. So in lymphoma, if I tell you, can you say a few histologies which you would think of? Of course, you would want to confirm it with biopsy. 2, 3 histologies which would present with a mediastinal mass.
Ma'am, primary mediastinal B-cell lymphoma and the
Very good.
mediastinal gray zone lymphoma.
Which lymphoma?
Mediastinal gray zone lymphoma.
Very good. Then more
High-grade,
common.
high-grade lymphoma.
Okay. Not a PMBCL, but a high-grade B-cell lymphoma like a DLBCL. Then another one which presents with a mediastinal mass. Say an adolescent male is coming with a mediastinal mass with pleural effusion and all that. Any other differential? You're focused only on B. Is there any other type of lymphoma?
Ma'am, T-cell lymphoma.
Which
Anaphylactic
lymphoma?
lymphoma.
No, mediastinal mass with SVC obstruction. You are talking always about B. There is another letter, no?
T, ma'am.
Yes.
T-cell lymphoblastic
Lymphoblastic lymphoma by leukemia. Okay. So the common histologies which you should think of are non-Hodgkin's lymphoma and Hodgkin's, of which non-Hodgkin's will be top, Hodgkin's will be lower down. Why Hodgkin's is lower down?
Ma'am, because of the delayed growth and invasive nature, ma'am. Slow
Because
invasive
there
nature.
is SVC obstruction, so Hodgkin's comes lower down. So the
Yes.
upper one would be non-Hodgkin's lymphoma, of which you would think of B-cell lymphomas like primary mediastinal B-cell lymphoma, other high-grade B-cell like DLBCL, T lymphoblastic lymphoma, and rarely a gray zone lymphoma. Okay. So these would be your differentials at the end of your history and examination. How are you going to approach this patient, or how are you going to evaluate this patient?
Ma'am, I would like to do the investigation. One is to confirm the diagnosis. Next is to
good.
state the diagnosis, and next to take the to assess the fitness of the patient for the therapy. So to confirm the diagnosis, I want to do the um, biopsy and the imaging, ma'am. Imaging, I would like to do a PET scan, and
Okay, just 1 minute. Just hold on. So the first word which you said is for diagnosis, you would do a biopsy, right?
yes, ma'am.
Okay. So I will give you a clinical scenario. The patient's blood count was done. Hemoglobin is 6.5. Total count is 2 lakhs and platelet count is 10,000. What will happen if you do a biopsy for this patient?
Ma'am, can you repeat the question?
No, you said your first investigation is going to be a biopsy, right?
Ma'am, before biopsy, I would like to do the routine blood test.
Yes. So that is very important. So that's what I said when you're presenting. Please think that you are in your OPD or in your emergency casualty. This patient has come to you what you're going to do for that patient. Just think in that way, just be relaxed and give your answer. A patient with a mediastinal mass with SVC obstruction who is hemodynamically stable. In any, you are thinking of lymphoma, right? So in all
Yes.
hematological malignancy, which is going to be your first investigation?
Then CBC I want to do, and peripheral
Yes.
smear, and
Very
renal
good.
and liver function test,
Yes.
and the
So
coagulation
first
profile.
thing is complete blood count. Second is a peripheral smear. Third, as you said, it's a very short history. So you're thinking in terms of a high-grade disease. So you would do biochemical investigations to rule out tumor lysis syndrome, right?
Yes.
So before a biopsy, the first investigation is always complete blood count with a peripheral smear with renal function, electrolytes, liver function, LDH. And if it was a male patient, what else you would do in the blood?
Ma'am, the tumor markers, ma'am, beta
Tumor
HCG.
markers, AFP, beta HCG, and
Ampok.
LDH. Okay, this patient is hemodynamically stable. Suppose this patient was mediastinal mass with SVC obstruction in respiratory distress. Patient has a saturation of say 88%. Patient is tachypnic. Pulse rate is 130. Blood pressure is 100/60. The patient has come to the emergency. So before you do a biopsy, what will be your first step?
Um,
Clinically, what will you do for the patient in your management in the emergency? The patient has come to the emergency. The patient has SVC obstruction, which is clinically obvious. You don't need a PET CT to diagnose that. The patient is in respiratory distress. What will you do first?
Ma'am, first I will stabilize the patient with the
Very good.
and all, and I will send the blood test, and I'll see the electrolyte imbalance and all. Then I'll try to
Okay,
correct that.
okay. So we will stabilize the patient with bed rest, head and elevation with oxygen inhalation. Where will you where will the where will the cannula be put? Upper limb or lower limb?
Preferably the lower limb, ma'am.
Lower limb. Okay. In the lower limb, cannula is put and blood samples are taken. And at the time when blood samples are taken, you will do a complete blood count, a peripheral smear, investigations to rule out tumor lysis, and in a male patient, AFP beta HCG as well. Okay. So I'll make life simple. Coming back to your case, the patient is hemodynamically stable. You have done your blood counts are normal. You have the reports of this patient.
Yes, ma'am.
Okay. Anything abnormal? Blood counts are normal. Liver function is normal. Is there any evidence of tumor lysis? Renal function is normal. LDH is normal, right?
Yes, ma'am.
Okay. So what is your next investigation going to be for this patient?
Ma'am, since she has presented with
Yes.
a
Common investigation.
2D echo and venous Doppler, I would like to do.
Do you want to do an X-ray, portable X-ray?
Yes, ma'am.
How will the X-ray help you?
First, we try to localize the whether it is in the mediastinum to the superior mediastinum or
Okay.
the inferior mediastinum. In the inferior mediastinum, whether it is in the anterior or not.
Okay. More important than that. That is quite obvious from your history. Anything else which you can find in an X-ray? And of course, clinically in your clinical examinations, respiratory system examination was normal, but something which you can easily find out in an X-ray.
Bulkiness of the tumor, ma'am.
Okay. And if there is a pleural effusion, lung lesion, all this can be made out in a plain portable X-ray bedside. Okay. Next, how are you going to continue with your evaluation? Have you reached a diagnosis as yet?
No, ma'am. 2D echo I have done, and it's got to know there is a kind of a mass in the right atrium, which is more likely of clot, and ejection
Okay.
fraction 60%. Venous Doppler is showing the large thrombus in the internal jugular vein and SVC, which is extending into the right atrium also.
Mm-hmm. So-
PET scan, we got it done.
Mm-hmm.
PET
So you
scan
did
is,
a book. Can you please
Yes,
go to the previous slide?
yes, ma'am.
So you have just mentioned all the investigations you have done, right? Okay.
Yes, ma'am.
Bone marrow CSF won't come here. So just skip that. Go to the next slide.
So,
Okay.
ma'am, this is the PET scan, ma'am.
Okay. Tell me, what are the findings that you see in this PET scan?
Ma'am, there is a mass in the anterior mediastinum, which is measuring around 5.5 into 5 into 6 into 5 centimeter, which is eroding the surrounding vessels.
Mm-hmm.
The report says heterogeneous enhancing soft tissue mass, which is seen involving the anterior mediastinum of the right upper lobe, and it has seen conglomerating with the adjacent enlarged prevascular node. Entire mass measures approximately 5.5 into 6.8 into 8.7 centimeter with a SUV of 34.3. Mass is seen infiltrating into the superior vena cava and the proximal part of the azygous vein, and also seen extending into the right atrium. Posteriorly, it is abutting the right main bronchus. On medial aspect, it is seen abutting the ascending aorta. Anteriorly, it is showing showing adjacent pleural involvement with no obvious intercostal muscle infiltration or erosion.
So what is causing what is the mediastinal mass which is causing the SVC obstruction? It's a mediastinal nodal mass.
Yes, ma'am.
Extending into the right upper lobe of lung. It is infiltrating into the SVC, right?
Yes, ma'am.
Okay. And what else is significant here? There is a tumor thrombus and there is minimal bilateral pleural effusion. Anything else? Anything else in the PET CT? Only the mediastinal?
Abdominal nodes also, ma'am.
Okay. So supra and infradiaphragmatic lymph nodes are there.
Yes, ma'am.
Right? With minimal pleural effusion, and there is thrombosis of the right brachiocephalic vein.
Okay.
So what are you going to do next?
Ma'am, since the patient is hemodynamically stable and her Doppler and PET scan is showing the mass and tumor thrombi, I will start her on anticoagulant. Then I'll stabilize her. Then I'll take her for the CT guided biopsy. Ma'am.
So how long will you anticoagulate before you decide to biopsy her? 1 week, 2 weeks, 1 month, 6 months? What duration of anticoagulation?
Ma'am, at least we'll give 1 to 2 weeks, ma'am. Then we'll take the biopsy.
George, you want to add something?
And agree with that answer. It is likely to be a tumor thrombus as written in the PET scan. So do you think this anticoagulation is going to help her?
No, sir.
So this is a tumor thrombus. So what is important is in an SVC obstruction, SVC syndrome, is to reach a diagnosis at the earliest and to start appropriate treatment, right? So once a biopsy is taken, maybe we can start anticoagulation that we can discuss later. So the first step is to reach a diagnosis at the earliest before the patient goes into hemodynamic instability, right? In 15 days, fortunate for us, the patient is hemodynamically stable. So what we need to do is get a biopsy at the earliest so that we can reach a diagnosis at the earliest, right? So from where will you biopsy in this patient? Does the patient have any peripheral node which can be biopsied?
No, ma'am.
No. So that is very, very important. In every patient, don't go by the scan. Go by your clinical examination. If you have a significant representative peripheral node which can go for an excision biopsy, go for that. That would be safer And that would be more representative than going for an image-guided biopsy. But in this case, because there are no peripheral nodes, we have no choice but to go for an image-guided biopsy from the mediastinal nodal mass. Okay, so you have done a biopsy, right?
Yes, ma'am.
Okay, so what did you see in the biopsy? You have the report with you?
Yes, ma'am.
Can you please, enlighten us about each line of this biopsy report?
Ma'am, it is a CT guided biopsy, and the core biopsy from the mass in the mediastinum reveals
Very good.
reveals a typical large cell lymphoproliferation comprised of cells with a ovoid nuclei, vesicular chromatin, small nuclei, and eosinophilic cytoplasm. These cells are accompanied by large number of histiocytes. The lesional lymphoid cells expresses CD20.
Okay, just hold on. So the
Yes, ma'am.
first part of the biopsy, which you mentioned, is the morphology, right?
Yes, ma'am.
What are the most important words in this morphology, which should come to your mind when you're reading the whole story?
Ma'am, it is depends on the size of the cell
Very
and
good.
whether it is a focal distribution or it is a diffuse
Yes,
distribution of the cells.
very good. So the first word is atypical. Large cells are seen. Second, it's mentioned that there is a diffuse effacement, right? The
Yes,
core
ma'am.
biopsy is all the cells are the atypical large cells. So there is a diffuse effacement with atypical large cells, right?
Yes, ma'am.
Okay. So at this point, just based on this morphology, what would be your pathological differentials? We'll focus
Ma'am,
only on lymphoma. Which all lymphomas would come to your mind when you just read this first line alone?
ma'am, it is large B-cell lymphomas like DLBCL and
Okay.
high lymphomas and anaplastic lymphoma. Then large plasmocytic plasmablastic lymphoma.
37-year-old lady with a mediastinal mass. Keep that in mind.
Then it is high grade lymphoma, then primary mediastinal lymphoma.
Okay, very good. Okay, so we have the morphology first, where you have a diffuse effacement with large cells. Okay, so now you go to the immunohistochemistry. What are the lymphoid cells expressing?
Ma'am, it is expressing CD20, 30, and BCL6, and are immunosensitive for CD3, 5, and 10 and 23. MUM1 is negative and BCL2 is negative.
Okay, so CD20 is positive. What does that tell you?
Ma'am, CD20 is positive. It is showing
What is
B-cell.
the cell of origin? CD20. Anti-CD20 is which antibody?
Ma'am, it is a B-cell marker and it is
Yes,
a
very good.
germinal marker.
No, CD20 says it's a B cell marker. Okay, next you have mentioned it is CD30 positive. What does that signify? Can you say few lymphomas which can be CD30 positive?
Ma'am, it is positive in Hodgkin's lymphoma also. It is positive in few of the mediastinal lymphoma, like primary mediastinal lymphoma also.
Okay. Anything else?
It may be positive or negative in mediastinal gray zone lymphoma also.
Okay. Any other lymphoma which can be CD30 positive large cells? Okay, I'll tell you. So CD20 positive means it's a B cell lymphoma. CD30 is commonly positive. One is in Hodgkin's. Second is in anaplastic large cell lymphoma. Third is in around 70% of primary mediastinal lymphomas. And it's CD30 positive DLBCL. And of course, you have CD30 positive primary cutaneous lymphoma. So out of this, primary cutaneous lymphoma is out. There are no cutaneous lesions here. It is not an ALCL. Why? ALCL belongs to which category of lymphoma? Is it a B or a T?
It is a T cell, ma'am.
ALCL is a T cell lymphoma. Here we started with CD20, right? So ALCL is out. Can this be Hodgkin's lymphoma?
No, because Hodgkin's lymphoma is a small cell, and 15 will be positive. 15 and 30 will be positive, ma'am, along with this.
Very good. So in Hodgkin's lymphoma, this is not the morphology. In Hodgkin's lymphoma, the Reed-Sternberg cells are very few, and majority would be the inflammatory cells. So here they have said occasional histiocyte seen. So if it was a sea of inflammatory cells with one or two Reed-Sternberg cells in between, that would be the morphology of Hodgkin's lymphoma. And what would be the IHC there? As you rightly said, CD30 positive, CD15 positive. What do you get when you add 30 and 15 together? You get CD45, that is LCA, which is negative. So here CD30 is positive, CD20 is also positive. So the morphology and the IHC is not fitting into Hodgkin's lymphoma. Okay, so CD20 is positive, so we know it's a B cell lymphoma. CD30 is positive, and we have mentioned that CD10 is negative. What is the significance of CD10 here? What is CD10 in B cell development? What does CD10 denote? I can give you a clue. It is in the last, that GC subtype, Hans algorithm, all that is written there.
Yes, ma'am.
CD10.
It is a GCB, ma'am. It indicates.
Yes.
Hence, the
Very good.
algorithm.
Yes. So which are the two markers which suggest a germinal center phenotype?
CD10 and BCL6 positive, ma'am. And in ACB, it is BCL6 positive or negative, then MUM1 positive, ma'am.
Okay. So it's very important. Two important markers to remember for a germinal center is, so when you think of, say, a circle with a center, so in the center, one is, you think of BCL6. Just think that you have a round and you are extending it and making a 6 out of it. So BCL6 is a germinal center marker. And second is, you have the circle, put 1 to the left or right or whatever. So that becomes 10. So CD10 and BCL6 are the two germinal center markers. So when CD10 is negative, BCL6 is negative, that means it cannot be germinal center. So CD10 is a germinal center marker. Now, last two lines are very important. MIB is 50%. What does that tell you?
Ma'am, it measures the proliferation of the malignancy, ma'am.
Okay.
And
CMYC is 70%. What does that tell you?
ma'am, CMYC is expressed by approximately 70% of the lesion. So it is a proliferative thing, and double expressor one of the marker, ma'am, CMYC and BCL2.
Okay. So when you see CMYC, which is the lymphoma that comes to your mind? The most aggressive of all lymphomas.
The Burkitt's
starts
lymphoma.
with B. Burkitt. So the CMYC is written here. It's a B cell lymphoma. If I say this is Burkitt's lymphoma, am I right or am I wrong? Examiners might try to fool you.
Ma'am, but in Burkitt's lymphoma, the proliferative, the Ki67 is more than, it is on an equal to 100%. It is high proliferative.
Sure. Very good. So this is unlikely, or this is not Burkitt's, you can confidently say. One, clinically, mediastinum is not a common site for Burkitt. In your labs, LDH was normal. There was no tumor lysis. These are large cells. These are not the medium-sized typical Burkitt cell. The morphology is not that of a Burkitt cell. MIB is only 50%. In Burkitt's, it's close to 100%. And among the IHC markers, CD10 is negative, which is classically CD10 is a germinal center marker, which is usually positive in Burkitt's lymphoma. Okay. So putting all this together, finally, what do you think this is? This is diffuse effacement. It's a large cell. CD20 positive. So putting all the three together, diffuse large B-cell lymphoma, right?
Yes, ma'am.
Understood. Morphology, there's a diffuse effacement. Cells are large, so diffuse large. CD20 positive, so diffuse large B-cell lymphoma. So why do you want to elaborate further on this diffuse large B-cell lymphoma? What type it is? Any histological subtype you want to say? In between,
Ma'am,
you just uttered a word and then you swallowed it. It becomes important from the management point of view. All DLBCLs are not the same.
it is high-grade lymphoma with c-MYC and BCL6 positivity, ma'am.
Okay. c-MYC is positive and
BCL6 is positive, so it is double expressor, ma'am.
okay. It's a double expressor DLBCL. Is it double hit or double expressor?
Ma'am, if there is a gene amplification, then we call it as a double hit. If it is only the expressor, then
IHC, you would say it is double expressor. Usually, what is the cutoff that is taken for c-MYC, BCL6 and BCL2 to say
30%.
that?
More than 30%.
Which one?
More than
No,
30%, ma'am.
No, for c-MYC, it's usually 40. For BCL6, BCL2, it's usually 50. That's okay. So you have taken it as a double expressor DLBCL. If I say that this is primary mediastinal B-cell lymphoma, am I right or am I wrong? Is it same as DLBCL or is it something different? Because it's a 37-year-old lady. Is there something which you want to say that this is PMBCL or this is not PMBCL? Don't worry, in exam, nobody will screw you so much. Just because the discussion is on lymphoma and you have this pathology here, that's why we are just asking you. Don't get tensed about it. What is for PMBCL here and what is against PMBCL here?
CD30 is a strong thing, so it can be a primary mediastinal lymphoma. And,
so let's start with clinical. Clinically, what is suggestive of a PMBCL? What is the usual age group? What is the usual presentation? Usually it is seen in a young female in 30s. What is the most common presentation? The commonest site of disease? Primary mediastinal B-cell lymphoma.
Yes, ma'am.
Yes, so clinical presentation is fitting. It's a young female in 30s with a bulky mediastinal mass with SVCO, right?
Yes, ma'am.
In the PET-CT, there are some infradiaphragmatic node. Does it go against PMBCL or is it still compatible with PMBCL?
Ma'am, PMBCL, there's this one. PMBCL can occur in other place also, other than the mediastinum also.
Yes.
In the cervical also,
Very
it
good.
can occur.
Very good. So when you say primary mediastinal B-cell lymphoma, it's not an anatomical diagnosis.
Yes, ma'am.
It is a unique clinico-pathobiological entity. Clinically, pathologically, biologically, it is PMBCL. You can have disease in the mediastinum. You can have disease in other sites as well. Only in 80% it will be stage 2 BX. In 20% it can be advanced. You can have infradiaphragmatic disease as well. What is against in the morphology? What do you see classically in PMBCL? I'll tell you. Classically, it will be clear large cells with compartmentalizing sclerosis. And what is different from Hodgkin is, Hodgkin is a sea of inflammatory cell with the malignant cell in between, while here there will be no inflammatory cells. So clear 2 C's you have to remember in PMBCL. Clear large cells, compartmentalizing sclerosis. So there will be sclerotic bands dividing the cells into different compartments, and there would be no inflammatory cells. So that is what you will see in the morphology, plus IHCs which are adding to it. George, you were asking? Please go ahead.
What are the pathological features that differentiates a PMBCL from a diffuse large B-cell lymphoma? What is making PMBCL a separate entity as per clinical parameters ma'am has already mentioned? and what are the pathological parameters?
So it's CD30 positivity, and in DLBCL it will not be there. And DLBCL, BCL2 and BCL6 and CMYC will be there.
Okay. There is, as ma'am mentioned, there is sclerosis and fibrosis, which is more in PMBCL, but in a DLBCL of any other site, you won't find that much of sclerosis and fibrosis. The other thing with regard to the molecular, if molecular tests are done, there is increased prevalence of NF-kappa B amplification as well as PDL1 ligands in PMBCL, which is not seen in other DLBCL. Now, what is the cell of origin for PMBCL? Yeah.
It's in the mediastinum. That is a clue. Is it a B cell or a T cell? Primary mediastinal B cell lymphoma. So it's a B cell.
B cell.
What is the cell of origin? Some structure which is there in the mediastinum. Okay, you can go and read up. Very good. So, as George said, you have clear large cells, compartmentalizing sclerosis, which may be difficult to appreciate in a small biopsy, and there will be no inflammatory cells. And 2-3 times you mentioned about CD30. There is nothing like all DLBCLs will have CD30. Around 20% of DLBCLs can have CD30, but it is relatively rare. While in PMBCLs, around 70% can have CD30 and CD23. So it's a clinico-pathobiological entity, and PDL1 expression is more in PMBCL. That's why in PMBCL, in the second line setting, pembrolizumab is approved for use in second line setting. So at the end of all your history, examination, and all investigations, if I would tell you, just summarize and give your final diagnosis, what is your final diagnosis going to be?
Ma'am, 37 years old, presenting with a feature suggestive of SCCO with no generalized lymphadenopathy, and PET scan and the biopsy is suggestive of a non-Hodgkin's lymphoma of DLBCL variety, and it is stage 3, and IPI of IPI of 1 month.
Okay, stage
So it is
3,
for
after stage 3, do you want to add any other alphabets to it, or you don't want to? If I say it is stage 3 AEX, do you want to refute my diagnosis, or you are saying yes, ma'am? Please speak, you know the answer.
So
Yes.
they
You know
constitutional
the answer,
symptoms
just confidently say.
are not
Yes.
there, and it's not a bulk. Yeah, it is not a bulky disease.
So if I say stage 3 AEX, do you want me to write A and B here, or you don't want me to write A and B? Anyone can answer in the chat box. So you said your final diagnosis is non-Hodgkin's lymphoma, diffuse large B-cell lymphoma, stage 3.
Ma'am, A and B is one is A is a constitutional and B is a B symptom, which is used in Hodgkin's lymphoma, but not in non-Hodgkin's lymphoma. And
So, very good. So as per Lugano, you don't want to write A and B because it is non-Hodgkin's lymphoma. Okay, fair enough. If I write 3AE, why do I want to write E? Do you want me to write E, or you don't want me to write E? And what does E mean?
E stands for extranodal involvement. So here
Okay.
like in the mediastinum, we have a nodal mass only. So it is not an extranodal thing, ma'am. So the
You said
extranodal
something about the upper lobe of lung or something, no? So lung would be nodal or extranodal?
lung is extralymphatic, ma'am.
Okay, so he is there or he is not there?
He is there, ma'am.
There. So what is the peculiarity of this extranodal site in this particular patient? It is a mediastinal node, it's a contiguous involvement of the lung as an extension from the mediastinal node, right?
Yes, ma'am.
Okay. And is it bulky or non-bulky?
Yes, ma'am, it is bulky. More than 7.5 centimeter in DLBCL is considered as bulky.
Okay, so how are you going to manage this patient? Just practically, the patient is there. You have to write the practical. The patient is there. You have to write the orders for this patient. So we have the patient is hemodynamically stable. You have done the biopsy. PET scan is done. You have a diagnosis. How are you going to manage this patient? You did the biopsy. You called up the pathologist. The pathologist said it is lymphoma. While waiting for the final IHC report, will you start something for this patient?
And because it is a bulky disease, I want to go ahead with a pre-phase chemotherapy with a endoxin just to reduce the bulkiness of the disease. Then I'll start with
Prephase is with endoxin alone or anything else? Any other
uh,
drug which is a backbone?
with the prednisolone, ma'am.
Steroids, right? So the most important is steroid. So if the
Yes,
patient was hemodynamically unstable, I would do a biopsy at the earliest, request the pathologist to expedite the report, and the moment they say it is lymphoma and the tissue is adequate, I would start with steroids with anti-TLS measures, right?
yes,
So in this patient, it's okay because patient is hemodynamically stable. You wish to give a prephase. Prephase will be with which all drugs?
ma'am.
Two
Prephase,
drugs.
uh, we have given in this patient endoxin and prednisolone, ma'am.
Sure. So endoxin and steroids were given as prephase. Anything else which you need to monitor very carefully while you are giving endoxin and steroids?
For the TLS profile, we have to monitor, ma'am, the electrolytes.
What all investigations you would do to monitor tumor lysis?
Ma'am, electrolytes I would like to do, and uric acid I would like to do, and creatinine,
And strict
and
monitoring of?
urine output also.
Okay. Strict intake output monitoring, vitals monitoring, and the investigations which you said. Do you still want to anticoagulate the patient?
Yes, ma'am. The last
Okay.
thrombus is there, so I will give the anticoagulation.
Okay. So after the biopsy is taken, you were started with anticoagulation also. So just prephase is started. 1 week later, the patient is quite symptomatically better. The swelling has all regressed. The patient is fine. Treatment is finished, or you will do something more. What will be your
Ma'am,
definitive treatment plan for this patient?
ma'am, for this patient, we have planned with a dose-adjusted REPOC because she's a female young lady and it is in the mediastinum. If we give the RCHOP, if the disease is not responding, we have to subject her for the ISRT or IFRT. So we wanted to avoid that. That's why we wanted to give it a aggressive management. That is dose-adjusted REPOC, ma'am.
How many cycles you would give?
Ma'am, since she is a safety and with a bulky disease, so I want to subject her for 2 to 4 cycles. Then I want to subject her for the interim site, assess the response, and go ahead with the other two. Depending on the response, I will go ahead with the other 2 cycles of the chemo. Total, in the beginning, we'll plan for 6 cycles.
George, you want to ask something more?
How will you administer rituximab for the first time?
Sir, rituximab is a chimeric antibody and it is known to cause anaphylactic reaction. So I will take proper precautions before administering the rituximab with diphenyl hydramine and uh, uh, and the paracetamol. Then I will start with I'll calculate the dose of rituximab 375 milligram per meter square, and the whole dose I will not mix it. First, I will give 100 milligram in around 100 ml. Then at a infusion at a level of 25 ml per hour, and I'll monitor her vitals every 15 minutes once. If she is not developing any anaphylactic reaction, I will give the next remaining dose also, sir. So the infusion timing is around, the first infusion timing is around 4 to 6 hours I'll give.
What is the dose of rituximab?
Some 375 milligram per meter square.
What are the vial strengths? In which all milligram strengths the drug is available? 100 and 500. Okay.
100, 500.
You mentioned about dose adjusted REPOC, right? What is the difference between REPOC versus RCHOP? I'm not talking of trial and evidence. I'm talking of how you administer the drugs, the difference in how the drug is given and difference in the drugs that are there in both the protocols.
Ma'am, R-CHOP consists of rituximab and cyclophosphamide, doxorubicin, and vincristine and prednisolone. So rituximab is 375 milligram per meter square, and doxorubicin 50 milligram per meter square, and cyclophosphamide is around 750 milligram per meter square, and prednisolone is 40 milligram per meter square. The R-CHOP is given in a single day, and it is in the daycare procedure. You can give and you can finish off the therapy, and no need of vigorous monitoring of the patient. And it requires growth factor support, but not much compared to the dose adjusted REPOC. In REPOC, for the dose adjusted REPOC, we have to hospitalize the patient for around 5 days, and the chemotherapy starts day one. The rituximab 375 milligram per meter square, and etoposide it is 50 milligram per meter square, and doxorubicin 10 milligram per meter square, and vincristine is 0.4 milligram per meter square. Prednisolone is 40 milligrams per meter square. So day 1 to day 5, day 4, we will give etoposide, vincristine, and doxorubicin, everything to be mixed in 500 ml NS over 24 hours with a hydration going on along with it. And along with that, we'll give the prednisolone oral tablets also, the 40 milligram per meter square, day 1 to day 5. And on the 5th day, we'll give cyclophosphamide 750 milligram per meter square.
How is it administered? Is it through a peripheral vein?
Ma'am, through the central line.
Yes. So usually a PICC line is inserted for the REPOC. Just to correct you, because all the doses which you mentioned, if you are confident about the doses, please mention it. If you are not confident, please don't say. Adriamycin is, I think, 10 mg per meter square. That's okay for the first cycle. And then it is dose adjusted. So you are going to escalate and de-escalate the doses based on the nadir counts in the previous cycle. Okay. Very good. Anything else?
Tell me, why is rituximab administered before chemotherapy? What is the logic behind administering rituximab before chemotherapy?
Sir, it is a chimeric antibody, and it. No, sir, I don't know the logic.
What is the mechanism of action of rituximab?
Sir, it acts against the CD20, sir. So
So please read up. For all anti-CD20 monoclonal antibodies, there are 4 common mechanisms which is nice for you to know. And it is a type 1 anti-CD20 monoclonal antibody. So once you reach this level, you will be asked questions related to rituximab, and more theoretical questions will come. So far, we were discussing from a practical point of view. So read up about rituximab, read up about monoclonal antibodies, their mechanism of action, infusion reactions, how you would manage it. Then we didn't touch upon gray zone lymphoma. What is gray about gray zone lymphoma? Why it is not black and white? And how do you manage a gray zone lymphoma? So those are some things which you need to read up. So overall, I think you've presented quite well. Only thing is, in the history, don't make it so elaborate because this is a DM level history. So try to make the history short and just mention the relevant negative history so that you
Okay.
get more time for your strong point. As I said, the art of case presentation is about navigating yourself through your strong point to reach the examination and to reach the diagnosis and differential diagnosis at the earliest. So, as you can also know, like the history part, the examination part was more difficult for you to answer, but once it reached the point of Archop, Haripok, you were able to answer much better. So make sure that your presentation reaches the level of management at the earliest so that you will be able to confidently speak what you confidently know. And that is what you do day in and day out. So whenever you are asked any question, don't think of Devita or your textbooks. Imagine you are sitting in your OPD with your consultant, with the patient sitting in front of you. Consultant is asking you a question and what you would answer. And that answer is going to be right in 99% of the situation. And if you don't know the answer, you just politely say that I'm not sure, so that you go to the next question. So I think you have done quite well. Your history you have elaborated and presented quite well. Examination also you have done it quite well. And the management part also we have discussed it. Just try to focus on the patient. And practice is what makes you perfect. You have done quite well. And make sure that the presentation that you do tomorrow is better than the one which you have done today. And I'm sure that at the end of 1 hour, most of us here have become a fan of Dr. Hemlata. So wishing you all the best and all success, and God bless you. So if you need any help anytime from any one of us, please feel free to email us or WhatsApp us. All the best.
Okay. Just to add on, please also go and read up about the long-term toxicities of chemotherapeutic agents, and also how do you clinically assess this patient each visit in OPD, and also the risk of infertility with chemotherapeutic agents. And I think you presented really well. It was a nice presentation. You answered also quite well. All the best. On behalf of Ampok, I would like to extend the thank you for attending this conference. And also I would like to thank Deepa Madam for the enlightening us with all the questions. Thanks a lot.
Thanks a lot.
Thank you, ma'am.
There is no difference. We give rituximab before or after. No difference. नहीं आर्टॉप में है आर्टॉप में people ask me question whether to give why are rituximab given before the chemotherapy.